Welcome to Assisted. I'm Chelsea Roff. Assisted dying is said to be a compassionate, caring choice.
But in this series, we explore why it's not that simple. I'm Finn McKenzie, and we'll look at why assisted dying has such a big impact on women.
Welcome back to Assisted. Fiona and I are delighted today to be joined by Professor Julian Hughes, who's been a doctor for 31 years and a consultant in old age psychiatry for over 20 years, and Baroness Finlay, a professor of palliative medicine who has been in the field for over 40 years and is a crossbench member of the House of Lords. Together, they've written a brilliant book, The Reality of Assisted Dying, which we're really excited to talk to them about and ask about today. So, Fiona, do you want to kick us off?
Well, I'm so excited to speak to you because you have so much experience of dealing with assisted dying in Parliament and also in understanding how assisted dying works elsewhere. So you wrote your book, you spoke to people all across the world. What were the kind of striking lessons you took from that experience?
I think from having looked at the way legislation goes around the world, that people start off very well-meaning, well-intentioned, thinking that this will be the solution to a problem, and very rapidly this legislation expands and more people get caught up and death becomes viewed as a solution to a problem. And the criteria that people think are really rigid and the safeguards actually turn out just to be vague qualifying conditions, and those, they move.
Staggering. Julian?
Well, I agree with Ilora. I think the other striking thing is how many lessons there are from around the world. And if I can just make a minor political point, it's therefore incredible that Kim Leadbeater's committee have seen, I think, hardly anybody who has been against legislation in jurisdictions where assisted dying is allowed. And just I said that I think there are so many lessons to be learned. So without pausing on them, because they may be things that we come on to discuss, there are things like people feeling a burden and therefore going for assisted dying because they feel that they're a burden. There's this interesting phenomenon that rates of non-assisted suicides go up in places where they've legalized assisted dying, whereas you might have thought they would go down, but they've gone up in places like Victoria, Belgium, the Netherlands. At the same time, and there's a nice table in the book which shows this, the rankings of places in terms of palliative care, in terms of the quality of palliative care, go down on the whole, not everywhere, but usually go down in countries where they've legalized assisted dying. So, for instance, Canada in 2015 was ranked 11th, and by 2021, after it had assisted dying, it was down to 22nd. Belgium went from 5th to 26th. I think the other thing we see in lots of countries is how few doctors want to be a part of this. And certainly the doctors who wrote from Australia said that there'd been real blurring of the boundaries between palliative care and assisted dying, which left them in a difficult position when they were talking with patients. We had somebody from Canada saying to us that suicide promotion, so in other words, if you're pushing medical assistance in dying, undermines suicide prevention. And the same author said to us that one of the things that he'd been struck by was how quickly in Canada assisted dying had been normalized, so he'd noticed it in medical students and in junior doctors. And just to end with one thing, so one kind of tiny detail in a sense, but another huge thing in another sense. There was a chapter by Professor Kees Hertog, who's a professor of geriatric medicine in the Netherlands, and he's someone who has euthanized people. And he said to us, and so he's undertaken research where he's looked at the impact on doctors who are involved in this. And there's one nice sentence in the book where he says, it is something you never get used to and that you always take home with you. And so I think these sort of things are just not being thought about in any detail.
Yeah, it does seem with this committee that there's a real aversion to detail. At least by my reading. Julian, perhaps I'll direct this one to you first, and then to Ilora, because it dovetails with what you just spoke to. Supporters of this bill, particularly Kim Ledbetter, have really insisted and reassured MPs that this bill will not expand if passed. It will not be amended. The safeguards, there's no slippery slope. Are you aware of any countries where assisted dying laws have remained strictly limited, or based on your research and what you saw in your book, do they inevitably widen over time?
Well, I think, as Ilora said, I think they do inevitably widen over time. I think the only countries where you haven't seen this is where the legislation has been passed quite recently, and so there hasn't been time for it to expand. In the book, there's a very good chapter by Scott Kim from America, where he says that it's inevitable that there will be this expansion of the eligibility criteria on the grounds of equality. So if you say, well, you're going to have it for terminal illness, somebody's going to say, well, I'm also suffering, so I should have it. And then people will say, well, I'm not just suffering physically, I'm suffering mentally, so I should have it. And then somebody will say, well, you're suffering, but you're age 70, but I'm suffering mentally and I'm only 16 years old, so I should have it. And the striking place, I suppose we saw it, was in Canada, where very quickly the initial thing was that that death had to be reasonably foreseeable, and then very quickly it spread to chronic illnesses like osteoarthritis and disability, and eventually it was any sort of psychosocial suffering. But we've also seen it in the Netherlands, where they didn't tie it in the Netherlands to terminal illness. They just said that your suffering had to be unbearable and hopeless. But nevertheless, most people initially were people with terminal conditions. But then again, over the years, it spread to chronic illnesses, mental illnesses, dementia, age-related conditions, lifelong disability, and children. And children are also included in Belgium. But the proponents of the bill will say, well, you're ignoring Oregon, because Oregon is the kind of model. But even in Oregon, there are minor changes. So, for instance, they got rid of the residency requirement, and they also got rid of, under certain circumstances, the 15-day cooling off period. But more importantly, we've seen in Oregon non-terminal conditions turning into terminal conditions. So these might be diabetes, but also anorexia, which of course Chelsea is an expert on all of this and has produced a very important systematic review of this. So there, I think there are worries in almost every country.
Yeah, and just actually, we'll go to Ilora in a second because I want to hear your thoughts too. But my sense is that assisted dying is a sort of global campaign, because they're quite well organised. It's actually been quite clever in that they haven't gone for huge countries first. They've gone for small states, for instance. And I don't think anyone's really noticed that England and Wales is maybe 10 times larger than Oregon or Western Australia or Victoria. And so actually the magnitude of how things can go wrong is potentially so much greater. And I find that quite interesting. Is your sense that there has been a sort of, that the various campaigning organisations in the US and Australia and across the world have been quite targeted in how they approach the initial rollout of this?
I would say you're absolutely right. Of course, these are all relatively wealthy countries with an ethos of libertarianism. Where what the person wants is paramount, where family connections often are less now than they were in the past, so integration across society is less. But I think you're right. The campaigners have been very clever in targeting places. If I can go back to Chelsea's question, though, about whether the law would expand, when you look at the way that the legislation is written that we're talking about, there are lots of instances where it says may rather than must in the text of the bill. So there's huge laxity around lots of criteria. But also, a lot of it is left up to regulation making. And a lot of those regulations are to be made and not even come to Parliament. So, in fact, they could just be rewritten behind the scenes very rapidly and broadened up enormously. And if it's not on the face of the bill, you really don't know how it's going to be worked out in terms of the way that this legislation will actually work in practice.
So for MPs who are going to think about voting potentially for this third reading, you're saying that if it's not on the face of the bill, you might not get to decide on lots of this again, ever.
They may never get to decide, because there are two ways that regulations can come before Parliament, which are called secondary legislation. One of them is by the affirmative route, so it is laid before Parliament and we can debate it. We can't amend it though, so it's an all or nothing. But then there's negative resolution, which is where it isn't presented to Parliament for debate. It's simply listed on an order paper. And if somebody wants to call a debate, they have to, what's called pray and aid. They have to raise a debate specifically to discuss it. Again, it's an all or nothing. And secondary legislation is hardly ever thrown out. And it is an all or nothing process. So I think it's very worrying that there is so little detail on the face of the bill over the assessments, and there's an awful lot about bureaucracy and paperwork. But actually, the assessments are the things that will determine whether somebody gets lethal drugs.
Yeah, because no one, those MPs are not going to be in the room when those happen, obviously. So there is a huge amount of trust placed in those people who are doing the assessments. But if the rules that govern the assessments aren't even going to be in front of MPs, because to be honest, what MP is going to have time, apart from possibly Danny Kruger, time and inclination to really hunt down what might be coming through, as a listed item?
This committee has thrown out amendments that would have made the bill safer. They have deliberately got rid of things that would have made the bill safer. And they've taken the judge as a final sign-off, and it was simply a sign-off. It could be viewed as a rubber stamping exercise, but that's gone, and it's substituted with a panel. But the panel don't have to interview the person who's applying. They simply take the word of one doctor. And if that doctor hasn't done the assessments very well, how would they know? They wouldn't know.
Yeah, I'm so glad you spoke to this. This was going to be my follow-up question around that negative procedure. Can you just to close it up, because I think many MPs may not be aware of this, that there are several very important consequential components of the bill that are subject to the negative procedure. Do you know, Baroness Finlay, offhand, can you give an example of one, and just to kind of lay out what that might look like? Do you know the drugs that will be regulated?
The drugs that are used to bring about death have never been approved anywhere in the world by any licensing authority. They have never been researched into how they bring about death. They are huge doses of drugs which would be used in much smaller doses, like 1/100th of this dose used or less, in a therapeutic way. But nobody's even done the research. And we know there are complication rates. We know the complication rate runs at about 6.7, 6.9% from Oregon. Now, for most medical procedures, you would not accept a complication rate that's that high. And we know that 9 people in Oregon have woken up again. We know from the Belgian data that the drugs used are the same or similar mixtures to those that have been used in judicial executions. And they've been abandoned in some judicial executions because they were viewed to be inhumane. And because the blood levels of executed prisoners have been assessed, and in 80% of them have probably dropped to a level that the person could have regained a degree of consciousness before they died. But because they're totally paralysed with a curare type drug and they're dying of asphyxia, then they look as if they're peaceful because they can't move a muscle.
Wow. Julian, if I could go to you, and it's a bit of a shift, but Oregon is one of the few jurisdictions in the world that publishes, I would not say excellent data, but some data and gives us some hint as to what's going on, particularly around the reasons people request an assisted death. And we know that the reasons often involve, as you said earlier, feeling a burden. Could you speak to a little bit of what you've seen in that data, either from Oregon or other jurisdictions in the US, in terms of the reasons people request an assisted death?
Well, so I think that the striking one is the one that we've mentioned, which is feeling a burden to family and friends. And so that's just under 50% in Oregon, just over 50% in the state of Washington, for instance. But there are other things like feeling that you're a financial burden. Things like quality of life and feeling that the person might feel that they're lacking in dignity, that they've lost control. These are all also sort of mentioned, and of course they're not. I mean, they probably strike people as being not unreasonable. If you feel that you've completely lost all dignity, lost all control, and so on, lost your sort of sense of autonomy, it might seem to people that these are jolly good reasons for wanting to end your life if you're actually in that position. But of course, from the point of view of healthcare and medical care, that's what healthcare and medical care is there for. It's in order to help people to see that you don't have to feel like that. It's to make people feel more dignified. It's to make sure people remain clean and tidy and also not in pain. I mean, pain is also one of the reasons people give. But I mean, that's what healthcare exists for, is in order to help people to feel as good as possible, despite the fact that they may have illnesses. Just reflecting on my field of dementia care, I mean, it's perfectly so that issues about loss of dignity and so on are very can be very apparent in dementia care. So it's very easy to. But just to kind of get to the point, the point is that this depends on the environment in which the person is living. So if you don't take care of people, then of course they can end up with food all over the place, they can end up incontinent and so on. But if you're in a good quality healthcare care environment, then you don't need to end up with food all over the place. You don't have to end up smelling and so on. So it seems much better that we should try and improve care, and in particular improve the access to palliative care, than we should just kind of give up and say, everything's terrible and we can't do anything about it, when it's patently obvious that in many, many cases we're going to be able to do something about it.
Can I just add on to that? Because I do think that we know that our healthcare system at the moment is under huge strain and is failing people. But that is not a reason to have doctors give lethal drugs to patients to end their lives. And I think that's the real dilemma. Do we say, well, the healthcare system's failing, can't cope at the moment, and then we'll just accept that instead of improving that, we'll license doctors to give lethal drugs to patients under this legislation? And I think it comes down to a really fundamental issue about what society expects from its healthcare system, and whether it expects people to keep working to improve quality of life, or whether it is quite happy for people just to throw the towel in early.
The idea that someone might feel a bit worthless in later life, and we as a society go, that completely agree. Here's something that can give your life meaning and purpose again by killing yourself. I don't get it. I don't get it. And you're so right on the burden point. I think in Australia, I think Western Australia says that you must not give people assisted dying because they feel like a burden. So they try to anticipate this, but still maybe sort of 35-40% of people say I feel like a burden. It doesn't. So it doesn't work. Like this kind of. It seems to just be a machine for giving people death.
I was going to follow up that question and just ask, this week and last week on the committee, we saw MPs reject amendments that would do exactly what Fiona just spoke to, that would ensure that people are not given lethal medications because they feel a burden. We saw one this week around psychosocial assessments. I know you can't get into the heads of MPs, but why do you think, what was the justification for voting down what seemed to be very sensible safeguards?
I don't understand it, and I think that they are just determined to get this legislation through. And it feels as if it's being steamrolled through, and almost as if don't worry about the detail, feel the width. And that may be completely wrong, but I think it is very concerning that amendments that would have genuinely improved this legislation have been rejected by this committee. It's almost as if those that they are so fixed in their mind that if somebody comes up with an amendment that might improve it, they're automatically thinking, oh, this will destroy the bill. But it won't. The amendments that have been proposed very often have provided a bit more of a safeguard.
I mean, is your sense that this is viewed as a bit of it's a completely moral issue? So it's back to Julian's point that no one who's against assisted dying was invited to speak in committee. I mean, to be honest, even if I think that if you're slightly critical or reflexive on assisted dying, you seem to be pitched as being against assisted dying. I mean, I know that we will be viewed as being against assisted dying, even though I think both Chelsea and I approach this from being sort of in principle not against it. I mean, what is this? Do you think this bill is different to the? I know that this bill is presented as a once in a generation almost opportunity to get this in the UK, but is your sense that this bill or versions of it, which frequently appear in Parliament, this time it's different?
I'm not quite sure what you mean by this time it's different.
Well, in the sense that versions of this bill have been appearing in Parliament since the 1930s. So there's Baron Falconer has had a bill in the House of Lords last year. There was a serious attempt in 2015. There's been a couple of versions. So it's not like this is. I think if you remember the public, you'll feel like this is the only chance we've had in the last 10 years at least to have a bill of this type actually pass. But my sense is that actually there's sort of a fairly continuous attempt to make this law. But this time it is different. It does feel like there's real momentum behind this.
Well, I think that the difference is that this has been introduced in the Commons, whereas the previous ones were introduced in the House of Lords. There is something about the House of Commons being the elected chamber. And I think the campaign that's been waged to support the bill has had a huge amount of money thrown at it, and has been very cleverly run. I mean, you have to say, well, they certainly know how to run a campaign.
They do. They really do. I mean, I might edit this out, but do you have any sense of where's the money coming from?
I don't know. I don't know. But I mean, they have a lot of money. But I think there is something else going on, which I think is really terribly sad. And that is that a lot of people have had bad experiences at the time of somebody who they love dying. And they think that this will solve the problem of bad deaths. There's no evidence that it does solve the problem of bad deaths. What it does is it simply has people die months or possibly years earlier than they would have otherwise died because they are frightened, or they may be under the misconception that there's nothing more that can be done. They often will be unaware of what else might be an option for them. And my big worry is, what does this do to medical thinking? If you're going to have a system like this, then take it outside of clinical care. But I really worry that we need to have doctors and nurses focused on doing all they can to provide good care for people and enhance people's dignity, not abandon them to death.
Julian, I want to ask you a little bit about the safeguards that have been considered in committee so far, and what's not been passed. Are there any particular amendments that didn't make it through, that your concern didn't pass, or amendments you think the committee should be considering, or MPs should consider in report stage?
Well, just to be entirely egocentric for a second, I did suggest amendments myself, and then I was interested to see that MPs had also suggested similar amendments. So this was an amendment to say that you had to sort of the lack of the person's capacity had to be, I think they were using the word demonstrable, and I thought this was important because everybody just says the Mental Capacity Act is fine, we don't need to worry about it. But actually, and in many cases that's going to be true. But the thing we should worry about always are the marginal cases. And so in the marginal cases, it would be nice to see the doctors writing down somewhere, just as they have to do when they're doing a Mental Health Act assessment, writing down their reasons for saying that the person did or did not have capacity. And the other benefit of that would be that could then have gone to the judge, and the judge would have something to look at and could say, yes, this doctor's done a great job, there's no doubt about it, it's all chipper. But that was just dismissed, and it's very hard to see why it's dismissed when we have a good sort, we have the Mental Health Act where doctors have to write a couple of sides of A4 justifying why they're locking someone up. So if you're going to be killing someone or helping someone to kill themselves, you'd have thought that you might have to write more than a couple of pages of A4 to justify that. So anyway, that's my egocentric point, that they didn't like my amendment or similar amendments by other people. But then I was also struck very recently, in the last couple of weeks ago, when there was quite a long discussion about prisoners and people who were homeless. And it's interesting because you can see almost the logic of those who are in favour of the bill and don't want anything to interrupt its process. And you can see why they would say, look, the bill must just apply to anybody, so it doesn't matter, if you're in prison and you have a terminal condition and you're within 6 months of dying, you should be able to access the bill as well. But they failed to see that there's this real worry about coercion, and a sort of not just the external coercion, but also a kind of a feeling of internal coercion. So here's somebody in prison who is sort of rock bottom, and then they get told, "Oh, sorry, you've got a cancer or something," and then if the prison doctor then says to them, "Well, one option is assisted dying," you can see they'll think, "Well, what the hell? I might as well go for it." Just to highlight our book again, one of the chapters in the book is about diagnosis and prognosis. Diagnosis can be wrong in 30% of cases. Prognosis can be wrong in 50% of cases. So, this person who just says, okay, then I'll go for assisted dying, it may be that they shouldn't even be doing that. And if you think of somebody who's homeless, they really are kind of rock bottom. So if they get told, well, we think you've got a cancer, we think you might not live that long, they're inevitably going to think, oh, okay, this seems like a good option, rather than everything being done for them in order to kind of pick them up and help them, with the potential that they might live more than 6 months, and maybe it will turn out to be something that in the end is curable, or maybe it's a mistake and they haven't actually. Mistakes are made. People are told they have cancer and then they don't have cancer. So, it's these kind of marginal cases that we need to think about. And I thought it was quite odd that most of the committee thought that it was just fine to include people who are in prison and people who are homeless, offering them, as it were, assisted dying. It just seems to me a very risky thing to be doing.
It was framed almost as a right to a medical treatment. Assisted death was framed as a medical treatment, with a real, I felt, lack of understanding of as you spoke to, the vulnerability of someone who's incarcerated, who may not have access to good health care, mental health care, or health care for their other conditions. A condition can become terminal without access to health care. So I was really shocked to see that voted down as well.
The bill is going to go to the House of Commons. I have a feeling it might still pass.
I do too. I think it will.
I'm cautiously optimistic, my
No,
friends.
I think it will, because I think at the end of the day, MPs will want to please Keir, and they think he wants this. And I think many of them haven't read the bill. They haven't read around it. And actually, if you want to bring this in, you should scrap this bill, which is now a real mess, and start again and have something which is completely runs parallel to clinical care, which is really carefully thought through. And there have been suggested models, but the campaigners don't want them because they know that if it's in clinical care, it'll just at the end of the day be death on demand. And my worry is that this will be a way to cover up clinical errors because the doctor can suggest it. And if a doctor suggests something to you, then you make an assumption that they think this is in your best interest.
Well, maybe the question then is, one, if we have any MPs listening, and I know sometimes they do, please do read the bill. If it is a legal document, but there's some really important things there for both of you. If just one piece, is there one thing you would want MPs that are maybe sitting on the fence about this, that feel in principle it's a good idea, but I have some qualms about the safeguards? What's one thing you might want them to know?
I think, that there will always be sad cases where you think, well, actually, this person's death could have happened more quickly for whatever reason. And, when people die, people think, well, this is a relief. The way this bill is written and planned, it puts all the power in the hands of other people, and it doesn't make sure that people have real choices. They only have to be told what palliative care is available. If they're in an area where the services haven't developed well, they don't have a choice. Why aren't we pushing to have high quality NHS services everywhere? And then if you want to have an assisted death service, assisted suicide service, run it completely outside of clinical practice and have it with all of the stages of assessment carefully recorded so they can be audited and they can be monitored. Allow appeals in both directions, not just an appeal against a refusal, but if somebody in the family knows something that hasn't been disclosed, allow them to come forward and appeal. There are lots of areas where this bill is simply steering you towards death as a solution.
I agree with the point that we really need to improve palliative care, and that should be a major focus before we do anything else. I think that it's hard to think of a sort of single message for MPs, but maybe one which has just come into my head is to ask them to think seriously about capital punishment. And so capital punishment is an area where we know for certain sorts of crimes, over 50% of the population, and that seems to be increasing apparently, would like to have capital punishment. But so why don't we have capital punishment? And the main reason is because we know there'll be mistakes and there'll be people who are killed who shouldn't have been killed and so on. And I think it'll be very similar, if this bill passes, that is what will happen. There will be people whose lives will be ended who didn't need to have their lives ended, either when they were or at all. So if they're going to bring in, my challenge to MPs would be, okay, bring in this bill, but then bring in capital punishment and see if they like that. I'm sure they wouldn't.
Yeah, well, we know from Fiona's work that many of those wrongful deaths are likely to be women, particularly women in intimate partner violence.
And we all know about coercive control, and this bill will not detect coercion.
As Fiona, Chelsea and I were so keen that we start to hear some really detailed debate on what assisted dying could look like here in the UK for women. We do not have big money funding, so if you'd like to support us, you can go over to our Substack and subscribe there, or you can donate to The Other Half on our website, theotherhalf.uk/donate. So grateful for this and so grateful for you listening, though. Thank you.